Let me begin by thanking the Ireland India Institute for inviting me to this lecture. Thank you very much, Hari, Arpita, Eileen, and others for this. As we know, we are all facing a particular kind of crisis that we have never witnessed in the recent past. Even the 1918 Spanish flu did not lock down the world as it is locked down now. It's also a very important point to note that this is not just a health crisis. This is also an economic crisis. And that, in that sense, it's a humanitarian crisis as well. Economic crisis is in some sense very peculiar because economists of no hue have seen this kind of a pandemic in the past and this kind of impact that it has created across the world. This is a unique situation where it is not just a demand shock or a supply shock or a speculation in the financial market that has spilled over into the real economy. It is in some ways all of this together. It doesn't always happen that demand and supply fall together to create a unique kind of an impact where prices become totally indeterminate, even in theoretical terms. That is one key feature of this. That it creates an economic crisis which is in some sense very unique and does not have any examples from the past. The second is the fact that as the epidemic curve goes up, that is the number of cumulative infections go up, it becomes a necessity that you close down the economy in order to prevent further infections. And this means that the so-called economic curve, activity curve if you may call it, would go down necessarily. So there is a clear inverse relationship that exists between the upward sloping epidemic curve and the downward sloping economic curve. The economic curve has to go down if you have to, in some sense, prevent the epidemic curve from rather indefinitely going up. For it to peak or for it to plateau, for it to flatten, as we call it, the economic curve has to go down and reach a trough. And only from that trough can the economy revive itself along with the movement down the peak of the epidemic curve. So that's a second important feature. The economy has to necessarily go down, and that creates enormous crisis in the livelihood of people. So in many ways, it is a very unique crisis that we are facing. Now, having said that, let me right away come to the topic of this lecture, which is regarding the pandemic and what the public health system of Kerala looks like in this kind of a situation. I shall share my screen a little bit so that I'm able to show you some interesting graphs. I hope you'll be able to see it properly. Okay. Now, this is basically India's top 13 states as on 29th April. And you can very clearly see that on the leftmost side, there's sort of green with circle dots marked over it as the legend. That is Kerala. So at the beginning of the crisis, Kerala was one of the most acutely affected states. This had a few reasons. First is that Kerala is one of the most globalized states of India. It has workers in different parts of the world, and in particular, it has workers in the Gulf region of Kerala, Gulf region in the Middle East, where millions of Keralites work in different capacities. And because that was a sort of a hotspot in the beginning itself, a lot of people came in from the Gulf region back home in flights, and that created the initial scare of infections. The first infection, however, didn't come from the Gulf region. The first infection in Kerala actually came from Wuhan itself, where Indian students were studying, Keralite students were studying there, and one of the students there was detected positive on the 29th of January, and that was the first positive case that was detected from Kerala. So what I'm trying to say is it is a very globalized state, and people it is a very small state. It has only about 3% of the population of India, but at the same time, it has 4 international airports. That's the kind of global connectivity that the Kerala economy and society have. So that meant that it was immediately vulnerable to people coming in from global hotspots back home and for work, etc. That meant that Kerala was right at the top when the crisis began. But as the crisis proceeds, you can see towards the right side of the graph, Kerala never really goes up beyond a particular level. And in some sense, Kerala is invisible in that graph, primarily because it's almost lying asymptotic to the x-axis there. So, but at the same time, you can see the other states like Maharashtra, Gujarat, and so on, really going up as we proceeded. I'll show you another graph which will actually be more instructive in this. This is the COVID positive cases in Kerala as of 28th. You see the blue line at the top, which goes up, is the total infections, but the line which sort of I don't know what color it appears to you. For me, it's red. The red line which goes up and then comes down is the number of infected persons over a period of time, and the green line which goes up is actually the number of recovered cases. So you can see a very clear sort of inverse relationship between the number of the cases infected and the number of recoveries there. We are really in Kerala ramping up facilities to ensure that the number of recovered patients reaches the maximum. And as of now, Kerala stands pretty above other states in terms of where it stands with vis-a-vis infections, deaths, etc. I'll give you a small set of data to sort of illustrate that. The total number of COVID deaths in India as of 2 days back was 1,074. Out of these 1,074, how many were in Kerala? Just 3. So just 3 deaths have been reported from Kerala, while about 1,074 deaths have been reported from India. The national recovery rate is only about 25% from the virus, but the recovery rate in Kerala is about 75%. The death rate calculated from the data that's there is about 3.25% in India as a whole, which is something that you see across the world as well. But the death rate in Kerala is about 0.6%. So if you look at a number of these kinds of indicators, you will see that Kerala stands really ahead of other states in terms of its response to the COVID-19 crisis. And you would have seen articles in The Guardian, in the Washington Post, etc., which sort of reports this with quite some prominence. Now, why? Now, this. Let me come to why is this that Kerala was able to do this in some form. I would say that the very clear answer to that is ensuring that there was a very clear strategy to combat COVID in the state. You can see here that there was a clear multi-pronged response to combat the virus in the state. You can see that the first element of the strategy was on identifying the individuals with risk and going forward with a very rigorous contact tracing process. The contact tracing process in Kerala has been extraordinary in some sense, because Kerala has had some kind of experience in dealing with epidemics of this sort. When 2 years back it was infected with what is called as the Nipah virus, NIPAH. Nipah virus became quite a scare. It was localized in one particular district, but it was still it became quite acute at some point, and it was at that time, 2 years back, that Kerala's health system became extremely equipped with the ways and means to deal with an epidemic of this sort, identifying individuals with risk and embarking on a rigorous contact tracing process and putting together maps, for example, as to where each person was at each point of time and so on. That became quite an effort of the public health department. But that's not the only intervention here. Kerala also ensured extremely good quality home isolation for people, because it didn't want to burden the public hospitals and other facilities that it was still building to meet this crisis with cases. So it ensured good quality home isolation, where food kits, cooked food, etc., were provided to people at home who were undergoing home quarantine. And the third point was there was a rigorous surveillance system that was ensured, which was a combination of community surveillance as well as telephone-based surveillance as to whether you are at home, whether you are still at home, have you moved out. So without violating the privacies of people, there was a rigorous system of surveillance put in place to ensure that home quarantine actually works on the ground. Kerala was the first state to ramp up the number of tests within its population. Other states were very slow in catching up with this trend, but Kerala ensured that it had both the PCR and the rapid test kits made available, and the number of tests in Kerala in the initial stage were really very high compared to other parts of India. Other parts of India have now picked up over time, but the initial stages, this was much of the testing that happened in India was in Kerala. It also ensured a very interesting. It put together a set of volunteers to put in place kiosks at different public places, which would take samples of people. All those became a part of the strategy that was followed. So testing became a very important feature itself. Ramping up testing was a central feature of this strategy. Wherever COVID patients were there, the hospitals hospitals ensured that high quality care was provided to them, both in terms of basic medical care, hygiene, sanitation, good beds, and so on, alongside nutritious food packets, cooked food, etc. Enough number of ventilators were put in place quickly. There were startups which came up with new ideas of generating ventilator production techniques at low cost. Though production has not begun, that effort has really begun in a big way. Yet another feature of this strategy was extreme care that was given to the elderly, who are the most vulnerable to COVID-19, as we all know across the world. The health workers and care workers on the ground, including of a government program called Kudumbashri, which is a self-help group mechanism of women, they went from house to house asking for the number of elderly people living in each house and the health conditions of these individuals, whether they have a pre-existing health condition, and if there is a pre-existing health condition, do they need any specific assistance in terms of home quarantine? If home quarantine facilities were not available, that is, if the house was crowded with people, then they were taken out of that house, and other facilities were provided to these elderly so that social distancing could be ensured within the family as well. And this way, people who have a pre-existing vulnerability were isolated quickly and quarantined very effectively as well. The state government has been very effective in terms of providing information to people. Kerala Chief Minister Pinarayi Vijayan has been extremely forthcoming in meeting the press on a daily basis. In fact, it is jokingly said that the highest, the TV program with the highest television rating in Kerala today is the 6 p.m. live telecast of the press conference of the Chief Minister, where he completely with an enormous amount of transparency explains the number of tests that have been done that day, the number of positive cases, the number of people quarantined, which are the hot spots, and what the public communication has been very effective. The Indian Prime Minister has not even addressed a press conference as yet. However, what you see here is that the Kerala Chief Minister has been very forthcoming with information to people, information with scientific basis, not based on hearsays like you can inject some detergent into your body and so on. It has been based on science, based on advice by a group of doctors. Information has been had been sort of made available to people on a daily basis on the number of positive cases, the number of negative cases, the number of recovered cases, the number of home quarantine people, the facilities made available to them, what people should do during the lockdown, what precautions they should take. And as I said earlier, this has been one of the highly rated programs. About more than 200,000 people watch it on his Facebook page on a daily basis, and televisions, all channels telecast it live. And this has been a very important feature of the policy as well, public communication. So people are armed with information. There is no space for rumors, hearsays, etc. And authentic information is given to people on a daily basis by the Chief Minister himself. So all these, as you can see on the screen, it has been a multi-pronged strategy. All these have come together to create the effective response that Kerala has mounted to the COVID-19 pandemic. Now, this is a good time for me to sort of slightly come back a little bit and sort of look at what is it that makes Kerala so effective in terms of this kind of successful response. Now, Kerala is in some sense a state that is famous in the development literature for a set of reasons. That is, it is known for providing people with excellent human development facilities, even at low levels of per capita income. Now, in the WHO at one point called it good health at low cost. So countries like China, Sri Lanka, states like Kerala, Costa Rica, all these were regions which were put together into this category, where it was very clear that a rapid rise in per capita income is not necessary, it's not a precondition, it's not a prerequisite for good social development indicators to be achieved by a particular society. The trickle-down theory, usually put forward by the mainstream economic theory, argues that first growth should happen, and once growth reaches a particular threshold, the benefits from that will spill around. It will trickle down and reach everybody. Kerala, and we know, for example, that as the Pope at Vatican said recently, this theory was a hoax, primarily because he said we were told that please wait till the glass is full, and once the glass is full, the water will come out and everybody can drink the water. However, just a second before the water reached the top of the glass, suddenly the glass itself expanded, and it kept on expanding, and it never trickled down to anybody. So that's from the Pope himself. But coming back, the feature of Kerala has been that it showed to the world, it showed to India as well, that you do not need to wait for per capita incomes to rise above a threshold so that you can make available good quality health, good quality education, nutrition, etc. To its population. Now, there is some argument in the literature, which is only partly true, as I would argue, that the achievements of Kerala were in some sense historical in the sense that even before India attained independence, even during the colonial times, Kerala had achieved a certain level of human development, much ahead of other states in India. And and so much of this, much of the reasons for this success are located in a very early period, where there were elements of the enlightened princely states of the two regions within Kerala, Travancore and Cochin, and some actions of the British government in the British ruled part of Malabar, all of which are part of Kerala now. These were all these combined with certain social reform movements, etc., brought together a set of conditions whereby human development achievements could be facilitated better. Now, if my own argument in my writings and my other interventions has been that this is only partly true, in the sense that if you look at the data that is available on different health indicators, during the 1950s, Kerala became a state in 1957. But if you look at the data for the 1950s, you will see that Kerala's health achievements were, of course, slightly better than the rest of India, but it was nothing to be celebrated. If you look at the life expectancy at birth in Kerala, at that point of time in 1951 to 61 period, it was nothing more than 45. Okay, the life expectancy at birth. The infant mortality rate in Kerala at that point of time when it was formed was about 120 to 130. Now this is very high. So while this 120 was better than India's 140, IMR for India was 140, IMR was for Kerala was 120 in 1950s. Both are high. That is the point to note here. Even though Kerala is slightly better than India, the real expansion of healthcare facilities and hence the health outcomes occurred in Kerala after 1957, when the state became an independent state. It became an independent state within the Union of India. It elected a left government. In fact, Kerala is also well known in political science as the first region in India where a communist party was elected through the ballot paper, through an open election. So its first chief minister was a communist chief minister, and then occasionally it had communist governments. These governments put in place an extraordinary policy of social development, which focused primarily on education, literacy, health, nutrition, food security, cooperative action among people, and so on and so forth. So Kerala had after 1957 a set of policies put together which made achievements possible. So if the infant mortality rate was 120 in Kerala in 1950s, it is now at the level of about, well, depending on the definition that you use, it's about 11 or 10. Which is almost comparable to the Scandinavian countries, so to say. And you have almost 100% literacy rate. You have life expectancy rates which are 76 and 77 at that level, very near to 80. So all these achievements were made possible in the period after 1957 by an enlightened state policy. Now, this enlightened state policy was not just something that happened from above. It was also something that happened from below. And it is a combination of this public action from above and public action from below which made Kerala's success possible. This, in some sense, can be sort of summarized as something that brought together the different the resistance against different kinds of exploitation in the society under one platform. That is the exploitation based on class, exploitation based on caste, exploitation based on gender, all these based on religion. All these things were in some sense brought together under one umbrella, and there was enormous convergence of efforts by the state and political parties, civil society organizations, independent groups of civil society activists, etc., which came together to create this vibrant democracy that Kerala finally became in the second half of the 20th century. Now, this multi-pronged attack was very important. It brought together the resistance against class exploitation by ensuring that there was land reform, there was ensuring that there was education and health was made available to multiple sections of the population. The earlier social reform movements of the colonial period had, in some sense, laid the foundation for the reform movements within different caste groups, particularly the lower caste groups. The political parties of the left sort of took over this mantle in the 1940s and 1950s from these civil society organizations, from these social reform movements, and made it the legislative agenda of the state in some form. As a result, even when occasionally there are non-communist governments elected in the state, even these non-communist governments, which are otherwise follow a rather neoliberal policy at the central level, when this party rules Kerala, it is forced to follow the legislative consensus that has been built up over the years in the state, which is an enlightened program of social democracy. In that sense, this non-communist governments are also not able to touch the public schools or public hospitals beyond a particular point. So what brought Kerala's success to the world stage by the 1970s was this intervention by the government from the top and people's movements from below, which converged to attack caste, class, and gender-based exploitations and discriminations that existed in the society. There was large number of hospitals built during the post-1957 period. The large number of doctors and nurses and other care staff were appointed. There were child development centers created. Midday meals were introduced in schools. A rationing system was introduced across the state, which made universally available food grains to people at low prices. A strong cooperative movement ensured that workers do not lose jobs in areas where which are traditional in sense, which have much less mechanization and so on. They put together these people into cooperatives and ensured that these companies remained viable and employment was protected. So you can see that there were multiple levels at which historical problems of socioeconomic problems were in some sense addressed. Now, if you by the 1970s, thus Kerala reached some global stage in terms of its success in achieving good health at low cost, to use a WHO phrase. The United Nations called it a Kerala model by the 1970s. It came to be celebrated in different circles as a model to different countries, like Sri Lanka was, like Costa Rica was, or maybe Kenya was, and so on. But slowly, there were problems that were emerging internally in this kind of a system. These problems were primarily because the state was not growing fast enough economically. So it was unable, because of poor economic growth, it could not generate the revenues required to sustain the public health infrastructure that it had put out. Achieving it was easy at low cost, but to maintain it required some amount of fiscal space for which economic growth was necessary. So if you see the 1980s, you will see a phase whereby this kind of the renowned health system of Kerala begins to crack up a little bit here and there. Alongside, the health transition in Kerala slowly enters a third stage, whereby you also see a large number of what you call as second generation problems. These second generation problems are not the problems of the first generation, where people die because of simple illnesses, fever, or epidemics and so on. All those were controlled. Public health was provided at the basic level to people. But these new problems came up: heart diseases, diabetes, cancer, blood pressure related illnesses. All these became a problem, and the public health system slowly became a little incapable of dealing with this problem. This was the time when private hospitals came into play in a big way, and they became, in some sense, an important player in the public health, in the health system, healthcare system of the state. But what keeps Kerala distinct here is that these private hospitals were in some sense socially regulated through multiple means, whereby the kind of healthcare did not completely go out of access to poor people, even when these private hospitals were growing. Yet, public health scholars in Kerala understood the problem. They feared that if the situation was allowed to continue, then the health situation may reach a state of no return, and the old successes may simply be undone. And this is the time when a very historic intervention was made by the political left in Kerala in 1996, when it introduced a historic program of decentralization, which was called People's Planning Program. What the People's Planning Program of 1996 did was that it brought the local health systems, that is public health centers at the village level, the panchayat level, and the hospitals that existed at the level just above it, which is a large number of villages come together to form what is called as a block, which is the second tier of revenue administration in India. And then a number of blocks make a district, and a number of districts make a state, and a number of states make a country. These block hospitals, which were referral hospitals in some sense, people who cannot be treated at the public health centers at the ground level are sent to these taluk hospitals or block hospitals, and people who cannot be treated there as well are sent to the medical colleges that exist at the district level. So that kind of system existed for a while, but what decentralization did was to ensure that the control over these public health centers and the block level hospitals was entrusted with the local panchayats. And this meant a very qualitative improvement in the management of these public hospitals in terms of one of the reasons why people do not go to public hospitals is because people are worried about their hygiene, cleanliness, sanitation, and so on. There is a sense in which people are driven away from public hospitals. But this is a time when panchayats were asked to ensure that healthcare has to be taken care of in a rather holistic basis. Hospital management and administration is one part, which panchayats did very commendably during this period. They ensured that cleanliness was taken care of. They ensured that hospital works efficiently. The doctor is present at the hospital. The nurses are present at the hospitals. If there is a equipment that is damaged, that it's made sure that it is immediately repaired or replaced. These things were done very efficiently at the panchayat level and the block level, where these panchayats and blocks prepared what are called as annual plans of their own, for which there was a very clear budget allocated by the state government, which these panchayats and blocks could use on an untied basis. They are not told that they're just given the money. About 25% of the total plan of the state is actually given to the panchayats, and they are given complete freedom to decide on how to spend it. But they are told that do not ignore the certain sectors, like the productive sectors and the social sectors. So panchayats, in some sense, it was a very important democratic intervention at this time to ensure that local hospitals improve in quality. Now, this decentralization program that began in 1996, in some sense, began the reversal of the decline in Kerala's health system of the late 70s and the 1980s. What it did was that it brought back some amount of credibility to the public health system. It brought back the state in some sense. It deepened democracy using decentralization, and it made education and health a very fundamental agenda of the political process at the local level. And that meant that there was in some sense people's supervision, people's monitoring, and people's control over many of these public health institutions, which you do not see in other states of India. Now, unfortunately, in 2011, this particular government was voted out, and you saw some amount of lack of continuity in taking forward this process of decentralization and health. But the later left governments that came in 2006 and now in 2016, they ensured that this was taken forward, and the involvement of the local bodies, democratically elected local bodies, in taking care of the health system of the state at the local level, ensuring community participation. And that's a very important part of Kerala's success story. This kind of control of people of the system at the local level ensured that there was very effective community participation in this. So when finally in 2016 the current government of Kerala introduced a very far-reaching new intervention in the health system of the state, which was called, it's a term in the local language Malayalam, it's called Ardram, which is in some sense, which can be broadly translated as something that is provides a soft touch. And this was a very important initiative in the public health sector, where the state government ensured that there was a new energy that was brought into reinvigorating the public health system in the state. Here, the idea was all the public health centers that existed at the local level should be transformed into what are called family health centers. So you provide holistic family health care to sections of the population through this. You provide the best, you ramp up the number of doctors, number of nurses, number of care staff that are out there. You reform outpatient management procedures, provide hygienic and spacious wards in different hospitals, rooms, beds, toilets, etc., and ensuring that medicines are made available at low cost to people. And this Ardram scheme gave a new life to the public hospital system in Kerala, and that is another important feature of the system that we need to note here. I'll just show you one small photograph of one hospital that you might want to see. So, for example, this is a block level hospital. If you can see the photograph on your screen, that is a block level public hospital in the state, which was completely revamped as part of the Ardram program. It looks like an intensive care unit in a private hospital. It is not. It is a basic healthcare room in a public hospital at the village level in Kerala, and many such hospitals have been built. This is a hospital in a place called Punalur near Trivandrum in Kerala. So the public health system was enormously revamped, and new resources were made available to create new infrastructure, to create new, better and larger numbers of personnel, which in some sense enormously supplemented the already existing community participation model in the healthcare system in the state. Now this is when Nipah came in 2018. I'm sort of going back to Nipah here. Nipah was the first test of the revamped public health system of Kerala, where the old strengths of Kerala's health system combined with the strength of new initiatives was put on that pedestal, and Nipah said, show me what you can do. There's a nice movie, if you're interested, just an aside. The movie is called Virus, and it's probably available in one of those new platforms like Netflix or Amazon Prime. That's a very nice movie which shows how Kerala successfully dealt with the Nipah virus, where the enormous community strength was combined with the strength of the public health system, and there were the first efforts to identify the infected person, ramp up testing, contact tracing, that is the whole paths that the person has traveled over the last few days. I'll just I'm sorry to go back to this, but I will show you one or two examples of this. I'm sorry. Give me exactly a few seconds. So if you can see it on the screen, this is one example of a kind of route map that the public health system makes. Where this is case number 3 in a district. So he lands from Dubai airport on a particular day, and each moment there's a minute by minute assessment of where that person went. And for example, he walked to this hotel. From the hotel, he walked to the airport. The airport, he walked to this another hotel, had food from there, and he walked again to back to this hotel. And then he took an auto, and from that auto he went to this place. So he took a train. So all this was made available to the public through social media platforms and other communication systems. And this meant that every patient who was found to be infected had a route map like this. This was earlier done during the Nipah time, and that was repeated during the COVID time as well. So this model that Kerala in some sense has put forward is something that the central government has often said has often put forward as a model for other states to follow as well. This community-based health system based on participation of people with a strong involvement of the state, which comes in with investment and personnel. Now, that is a health part of the story. I shall have a few minutes more to just mention a few words about the economic side of it as well. Now, remember, as I said, this is not just a health crisis, this is also an economic crisis. Now, Kerala was one of the first states to understand the gravity of the economic situation that is unfolding, and when the central government had not even appointed a task force to look at the economic problems of the country, this state had already announced an economic revival package of about rupees 20,000 crores to be spent over the next 3 months, and spending is now happening. It ensured through these measures that free food was made available to people who are staying back during lockdown. Free food in the sense that food grains are made available for sale through the public distribution system, but that is not enough. Community kitchens were opened in every village. These community kitchens were open kitchens. Anybody could go and eat there, or if anybody is not able to go there, cooked food packets are made available from the community kitchens to each home. Milk was made available from the local Anganwadis, which are childcare centers, to ensure that infants less than 3 years of age are not deprived of protein-rich food. Milk and other protein-rich food items were made available to infants at their home during the lockdown period. Then there was also volunteers who ensured that if any elderly is at risk, they are quickly quarantined and taken care of in terms of their health care. All this required money. So enormous money was put together in this revival package for ramping up the healthcare system of the state, which was the first necessity, because only if you are able to bring down the epidemic curve can you think of bringing up the economic curve over a period of time. Now, the second feature of this was there was a cash transfer of rupees 1,000, which was announced for every household, which was not a beneficiary of any other social security program. It also ensured that all social security pensions that were made available to widows, to the elderly, to the disabled, to the traditional workers in the industries, etc., all those were paid upfront. In sense, there was a front loading of expenditures by the state. What the state would otherwise have spent in, say, 8 or 10 months from now, the state decided to spend it in 2 or 3 months. And in that sense, it became a very important revival package for the state, so which took care of the livelihood-related requirements of people as well. it ensured that some small money was made available to the needy sections of the society. Food was made available for them to survive and be well during the lockdown period. Some sections which were sort of kept out of all these things. For example, migrant workers. Kerala has a large section of migrant workers who reside in the state, who come from the eastern parts of India. Special facilities were made available to these migrant workers. In fact, one of the crisis points in every other state is that migrant workers have been complaining that they have been deprived of food. There's enormous hunger among them and so on. But there is very little, there are very few complaints of that sort in Kerala. Remember, Kerala is one state where there is not even one COVID positive case among the migrant workers of the state. The social distancing measures with community participation ensured that migrant sections of the society, which are of course the poorer sections of the society, are completely insulated from the COVID scare. That was a very important achievement of the Kerala model. So this kind of economic package that the state government announced, which looked after the healthcare sector, which looked after a part of the cash transfer, which looked after the food consumption part of it through making available free food. Also, it has self-help groups available across the state of women, largely poor women. Special loans were made available to these self-help groups in order to ramp up their liquidity and ensure that they do not fall into difficult states with respect to consumption, income, and so on. Now, this meant that it is not in the health sector that Kerala showed its way. It's also in the economic sector, where by proactively, much before anybody announced coming up with an economic package of revival, it ensured that some amount of economic relief was also provided to people during the period of lockdown. Now, I think I should slowly sort of wrap up my comments to begin with, and I can take questions from here on. What keeps Kerala apart? What has kept Kerala apart is, of course, the historical lesson that everybody has from Kerala, which is the importance of a strong public health system. Kerala's strength has been that it has not fallen for the fashionable private insurance-led models in the Anglo-Saxon world. It has followed largely the European model, the continental European model of making sure that there is a strong public health system in place with strong community participation, with a strong with strong governmental intervention and investment. And its strength historically has been the strength of this public health system. But over a period of time, this public health system was given away to panchayats. So democratic management of these institutions was ensured. Then came a program to take care of second generation problems, where hospital facilities were ramped up again in the more recent period, all of which together allowed the state to ensure that to begin with the Nipah of 2018 and now the COVID of 2019 and 20 is addressed with some amount of confidence, some amount of skill, some amount of experience, and that is something that most states in India and many less developed countries across the world have much to learn from. I will sort of close my initial comments there, and I look forward to questions that may come. Maybe we can discuss a few of them as well. Thank you very much.